Global awareness of prenatal alcohol exposure is high, yet at the exact moment of clinical intervention, the machinery of healthcare systematically stalls. A 2026 systematic review by Carey and colleagues evaluated international clinical guidelines to audit this exact gap. In a cascade model of 18 international guidelines, 94% recommend universal screening for prenatal alcohol exposure. But past screening, the data drops off. Under half provide clinical direction on medications. Further down, only 17% outline specific psychosocial treatment pathways for pregnant patients. The consensus among global health bodies effectively stops at screening. Clinicians are told to identify the risk, but are left without evidence-based protocols to treat it. This creates the maternal treatment void, a structural gap between identifying a high-risk pregnancy and actually managing the patient's alcohol use disorder. Advising a patient to simply stop drinking without deploying medical or psychosocial interventions relies on an obsolete understanding of addiction science. Failing to address maternal alcohol use significantly increases the statistical probability that infants will later enter the pediatric system with neurodevelopmental impairments. This operational failure shifts the burden. Healthcare moves from providing proactive maternal intervention to relying on reactive, highly specialized pediatric neurology. The inability to manage maternal alcohol use disorder dictates downstream outcomes. It overwhelms child welfare, disrupts public education, and stalls diagnostic infrastructure worldwide. Once inside that pediatric system, the neurological reality of fetal alcohol spectrum disorder makes post-birth diagnosis incredibly complex. Recent functional MRI research by Gupta and colleagues demonstrates this complexity by distinguishing ADHD with prenatal alcohol exposure from standard familial ADHD. This connectivity map illustrates their findings. Patients with prenatal alcohol exposure present specific hypoconnectivity across the frontoparietal network and cerebellar cerebral cortical systems. Isolating these specific neurobiological markers requires a multidisciplinary team of highly trained medical specialists. Operationally, that requirement creates severe bottlenecks. Waitlists for public assessments stretch for years, and private diagnostic processes can cost up to €34,000, as seen in Ireland. Relying exclusively on elite medical models limits access. It systematically strands the highest risk populations, those in foster care and the justice system, without a path to diagnosis. Bypassing these clinical bottlenecks requires a systemic alternative: decentralized, frontline biopsychosocial assessment. Models like Dr. Liam Curran's 5-step screening program relocate the initial evaluation from the specialist hospital directly into the community. Rather than waiting on neurologists, allied professionals like social workers and educators are trained to evaluate a child's adaptive behavior and executive functioning directly. This frontline data provides the exact information needed to implement functional interventions in classrooms and homes immediately, well before a formal clinical label is secured. Scaling FASD care requires decoupling behavioral support from the medical diagnosis. It is the only mathematically viable way to address the volume of affected individuals. When nations operate without codified cross-sector FASD frameworks, the macroeconomic reality becomes stark. In Ireland, longitudinal research indicates up to 62% of parents report consuming alcohol during pregnancy, yet the state relies on fragmented, localized responses rather than a cohesive national strategy. In South Africa, the national ASSD prevalence rate reaches an estimated 11%. This public health crisis is directly exacerbated by gaps in statutory policy. Without robust public health infrastructure, cultural myths flourish. Nearly a fifth of surveyed South Africans hold the dangerous belief that traditional beer, like umkombothi, is safer for the fetus than commercial alcohol. These localized myths discourage maternal screening, amplify stigma, and guarantee that affected children remain unsupported. In the absence of cross-sector statutory policy, clinical interventions will consistently be neutralized by cultural misinformation and systemic inertia. Several jurisdictions are successfully engineering the cross-sector integration required to break this inertia, namely Canada, Australia, and the United States. Canada is addressing this through federal legislation like Bill S-234, leveraging policy to target systemic inequities and reduce the over-incarceration of Indigenous populations. Australia is taking a macroeconomic approach, a $115 million investment, explicitly ties FASD management to their National Disability Insurance Scheme. In the U.S., the FASD Respect Act serves as a premier example of statutory architecture. The core mechanism of the Respect Act is a legal mandate. It forces historically separate systems, health, education, and justice, to coordinate their FASD responses. These frameworks represent a structural evolution. They move resources away from reactive medical funding and build proactive statutory infrastructure. The ultimate policy endpoint required globally is the establishment of an FASD-informed system. This system requires justice, child welfare, education, and healthcare to overlap, closing the maternal treatment void while building frontline assessment capacity. Success metrics must shift, moving away from diagnostic counting to prioritize functional support capacity, backed by cross-sector mandates. Public health advancement is defined by the statutory capacity to provide lifespan support, a transition that moves the focus beyond the limitations of clinical diagnostics.